All right, we're going to be talking about primary adrenal insufficiency today. This is commonly referred to as Addison's disease, and it can be also referred to as primary or chronic adrenocortical insufficiency. I have included pictures from osmosis on here. I think pictures are worth 1,000 words. I spent some time on pathophysiology because then we can understand signs and symptoms and how to treat the disease. I often refer to osmosis. I think they have wonderful pathophysiology slides, and other useful resources are Khan Academy if you need to get a little bit more simple or need a little bit more of a in-depth refresher. Okay, let's have a really brief discussion on the adrenal function and just a really quick overview. So the adrenal glands are on the cephalad portion of our kidneys. We usually have two of them. The adrenal gland has two different layers with very separate endocrine functions. So we have the cortex and then we have the medulla. Now, the cortex is made of three layers, and the outermost layer produces aldosterone, which is really important part of that axis or that family of feedback that works with the renin, angiotensin, aldosterone system, the RAS system. And basically, these hormones decrease potassium levels. They normally increase sodium levels. With sodium flows water, and it helps to increase our blood volume and our blood pressure. So they basically stimulate our sodium reabsorption, potassium excretion, and keep us balanced. Aldosterone is secreted in response to elevated levels of renin. So while it targets the distal convoluted tubule of the nephron, it also kind of helps manage that sodium-potassium ion pump, which helps with the urinary excretion of protons and moves the Barcar back into extracellular space to increase our pH. We're pH balance, right? I think there's a commercial about that. Okay. The middle layer is the zona fasciculata. The cells there make cortisol. This is a super, super important hormone. And it makes some other glucocorticoids. So cortisol is needed in times of physical, emotional stress. It comes in handy with our fight or flight situations. But when I say stress, this could also mean sepsis, sickness, etc. So recall that the hypothalamus releases that whole corticotropin releasing hormones, which tells the pituitary gland to release ACTH, and then that enters the blood. It targets the zona fasciculata of the adrenal glands, and then there it releases cortisol. So now we have cortisol into the bloodstream. It actually is very lipid soluble, and almost every cell in our body has receptors for it. Okay, so it's very easily passes through cell membranes, and in fact, it has a huge variety of functions, and one of its main jobs is to increase our blood glucose. So it promotes gluconeogenesis in the absence of free sugar. Okay, it causes it and goes to the liver, gluconeogenesis. Remember, that's how we make glucose from non-carbohydrate sources like amino acids or free fatty acids. It also gets the muscles to break down proteins, etc. So there's a lot of metabolic activity that's performed using cortisol. Basically, the cortisol is needed to help keep our glucose levels high when we need them, right? You can't go run if you're scared if you cannot actively access glucose. You're going to be weak. We need to have our body readily available to have that fight or flight situation. And then finally, our innermost layer is the zona reticularis, and the cells there make a group of sex hormones, which are the androgens, and particularly one of them is a precursor to testosterone. So in men, their main production of testosterone are in the testicles. In women, this is actually an important source of testosterone for us. So this kind of accounts for why we have such low levels of testosterone in women and higher in men. Then we have the medulla. I don't mean to leave that little guy out. He synthesizes, or she synthesizes, catecholamines. So this is where your epi and your norepi are made, and then our bioactive amines, peptides, histamine, serotonin, neuropeptides. A lot of fight or flight stuff. So what happens when our adrenals are dysfunctioning, when they're not functioning well? On the left here is from osmosis. It's a picture of when we have adrenal insufficiency. So insufficiency means we have hormone deficiencies. So this is a hormone output issue. Okay, this is hypofunction. It's usually malfunction of the adrenal gland itself, as in Addison's disease. There can be a secondary cause if the pituitary or the hypothalamus have been removed, if they're damaged, or if you've got another neuroendocrine dysfunction. When we have adrenal hyperfunction syndrome, so this is when we're having hypersecretion of hormones. There's often overlapping features, but we'll be discussing particularly Cushing syndrome, but it is going to be the opposite, as you can imagine. So what is Addison's disease? Let's talk about this hypersecretion of, hyposecretion, this dysfunction of our adrenals. It's actually very rare. The prevalence is maybe 4 people, up to 11 in about 100,000 people. That doesn't really prefer males or females. There's no racial preference. It can be acute or chronic. And then, of course, if you have a kind of a low chronic type that's undiagnosed, you can suddenly have an adrenal crisis. And this can be precipitated by stress. And it occurs in 3 to 11% of patients with this. So again, this is super, super rare. In adults, 70 to 90%, especially in the US, we automatically think of an autoimmune disorder. And it's atrophy, self-destruction, and it gets damaged over time. The remainder of the types are going to be from destruction. Important causes include carcinoma, so cancer can spread into the adrenal cortex. Other causes, actually the number one worldwide cause of adrenal dysfunction is TB. Other destructions can be infiltration from like hemochromatosis, amyloid disease, again, cancer, and other infiltrative diseases like sarcoidosis. In children, in the rare case, it is usually a congenital adrenal hyperplasia, and that's the number one cause. Okay, so we know what the function of the adrenal glands are. So now we know the function, we can kind of understand the pathophysiology of the disease and subsequently the signs and symptoms. So because mineral corticoids stimulate our sodium reabsorption and potassium excretion on a normal basis, a deficiency then would cause the reverse. So now we have an excessive excretion of sodium and we have decreased excretion of potassium, usually in the urine, but this can happen in sweat, saliva, and other exocrine glands. So now we have a low serum concentration of sodium. So we have a hyponatremia with hyperkalemia. In addition, where sodium goes, so does water. So this can result in dehydration, whether it's chronic or acute. And then we talked about the pH balance. So now we also have disturbances in our bicarb access, and we become acidemic. In addition, because we have our glucocorticoid deficiency, now this is going to contribute to our hypotension and causes severe insulin sensitivity and disturbances in all of our carb, fat, and protein metabolism. So now we have insufficient carbohydrate from our proteins, and we can't reach those glycogen reserves. And then now we're having neuromuscular dysfunction, weakness, and we're going to be at risk for infection and cardiovascular failure, basically. So another thing that the low amount of cortisol can cause is an increase in pituitary ACTH production, because it usually acts, there's usually a feedback mechanism. So then when you have high ACTH for a long time, it causes a increase in our blood lipoprotein, which actually stimulates melanocytes. So we end up getting this strange kind of hyperpigmentation. So the hyperpigmentation in the skin is actually not due to the adrenal insufficiency itself, but it's a secondary to the lack of pituitary feedback mechanisms. So now the symptoms make sense, right? You'll remember all of this. So we're having weakness, fatigue, orthostatic hypotension, right? So the primary adrenal insufficiency corresponds to directly which layers of the cortex are being destroyed. So the zona glomerulosa is destroyed. We lack aldosterone, so then we have electrolyte disturbances. And again, we're going to see that low sodium in the blood, high potassium. With low sodium in the blood, we have low fluid, right? So now we have a hypovolemic hyponatremia, okay? We're also acidemic because our pH balance is off. We might have, because of that, I think our bodies know something before we do, and before many times the clinician does. We're having salt cravings. People will come in automatically, dehydrated, nausea, vomit will ensue, and when you're acidemic, usually you will have some hypotension because you have some vasoplegia in addition to the hypovolemia, and then you can have severe signs and symptoms like orthostatic hypotension. You can have some cold intolerance if it's a low chronic issue. There are other problems that have to do with the decrease in androgen for women. They may have low libido. Men may have impotence. There could be some confusion because of the hypoglycemia and some cold intolerance, etc. So when I said you could have acute or chronic, you can actually have a really kind of slow chronic presentation of adrenal insufficiency. It could really easily be missed. So chronic primary adrenal insufficiency can be kind of insidious. It's very nonspecific. How many people come in complaining of fatigue, anorexia, especially older people, weight loss, just generalized weakness. If they've associated abdominal pain, cramping pain, muscle and joint pain, you might want to consider this. It's usually gradual and a nonspecific, and it could lead even to an incorrect diagnosis initially of neurosis if you're not checking their glucose levels, or if they're coming in because they just don't feel good constantly, right? And we just think they're somatic. So do kind of keep this in one of your peripheral differential diagnoses. If you hear weight loss, they're dehydrated, they're hypotensive, you've got positive orthostatic vital signs, be very suspicious. So the opposite of that presentation is going to be your acute presentation. So, you have this kind of chronic condition that goes unnoticed until there's a major stressor, like a serious injury. Maybe they have a big surgery, cabbage, abdominal surgery, some sort of infection, whatever the cause, all of a sudden the body has no ability to compensate. So there's a sudden increased need for aldosterone and cortisol because it's stressed out and the cortex can't deliver. So this is known as an adrenal or an Addisonian crisis. And it usually happens when the majority of the zona glomerulosa and fasciculata are destroyed. And the person might present with a sudden pain in the lower back, abdomen, legs. They're going to have severe nausea, vomiting, diarrhea, which of course adds to the dehydration that was already probably baseline. Hypotensive, then you're going to have peripheral vascular collapse. The body temperature could be low, but it also could be high, think about sepsis. However, not everyone mounts a fever. Or if it goes untreated, and they might be found comatose or not alive. In terms of the diagnosis, history is the key. We've paid attention to our patients and all of their vague complaints, and so we do our due diligence, and we'll usually run a BMP and a CBC, right? We're looking for normal things because we hear hoofs, right? But zebras do occur. So your classic electrolyte patterns are going to show a low sodium. They're going to look dry, right? This is not a hypervolemic hyponatremia like in heart failure or cirrhosis. This is a hyponatremic hyponatremia. They're going to have a high potassium, not necessarily acute renal failure. Not necessarily. Probably have a low bicarbonate because they can't make it. Maybe a high BUN. I don't know if anyway. So first thing you can do is get an early morning cortisol ACTH level. We do this frequently in the ICU. Do a spot check and we go, cortisol's less than 5 and they're intubated and in septic shock. Give them steroids. That's kind of our confirmatory test. We don't usually need to do a cosentropin stim test, which is the confirmatory test. So outpatient-wise, if you have a borderline result, you can do an ACTH stimulation test where you give synthetic ACTH. We just say let's do a stim test is usually what we say in the ICU. And then you measure your cortisol in hourly intervals. And if they return less than 20, they should have a change in their cortisol level if they're stressed. And I love that it's 20, right? What I tell my students all the time, if anybody pimps you about pressure, what's your CS? How high should your pressure be if you do a lumbar puncture? No higher than 20. What's your ocular pressure supposed to be? No higher than 20, right? Abdominal compression pressure, probably no higher than 20. Yeah, so your cortisol level should rise to 20. Okay, I love that number. Diagnostics don't necessarily have to be done. I would recommend them because you want to find the underlying reason. We want to do a renal ultrasound or CT scan, and although it's most likely autoimmune, especially in Western societies, you might be able to test for antibodies, but if it's a chronic issue, you may not find those in the rest of the world. And again, we have a lot of immigrants here in Houston, so it wouldn't be impossible for somebody to have chronic TB and have some infiltrates. So those will show up as calcifications. So we'll run a CT scan, make sure you're not finding cancer. If it's an acute presentation, you want to rule out a hemorrhage, okay, because that can cause an acute presentation. So because we understand our pathophys and our treatments, our adrenals make hormones. Since they can't make hormones, we need to replace the hormones. It's that easy. So think of salt, sugar, steroids, and support and search for cause, right? So the first line are going to be lifelong steroids, and the second line, which is also first line, is prevention, right? Prevention's preferable to cure. So if you have diagnosed somebody with Addison's, or they have adrenal insufficiency and they're going to be requiring some sort of surgery preemptively, or if anytime they get sick, UTI, you name it, sepsis, you're going to need to increase their steroid dose so that they can compensate for that additional stress. This is normally should be dosed twice daily because we have biphasic kind of rise in our cortisol levels. And so if you can't, you could do a daily dexamethasone. I don't know that I could take anything twice a day. So anyway, during a crisis, you're going to treat them kind of similar to a septic shock patient. It's very common that we just assume older people can't mount a cortisol response. So in septic shock, we often just empirically give hydrocortisone to support their access, and which has been interesting lately with the shortage of hydrocortisone. Then you're going to go give them IV fluids and glucose, probably epinephrine and all the things. That's the end of the presentation. I hope you enjoyed it. If you have any questions, please feel free to reach out, and here are some great resources for you.